So thank you all for joining us for another installment of our Endourology CM sessions for Northwestern. Today we have Dr. Matt Lee, who is a former fellow of mine and friend. He is a clinical assistant professor of urology at Ohio State University. He graduated cum laude from Yale University with a major in biology and went on to complete his medical degree at Columbia University in New York. He there developed his passion for urology and matched at University of Michigan for his residency. Following his residency, he did a 2-year fellowship, half of that in Indiana and half of that at Northwestern. So he's had a broad range of experience at different institutions, and he specializes currently in percutaneous nephrolithotomy and HoLEP. He's published multiple studies, research studies on both subjects, and to date has performed over 500 HoLEPs. Is that correct?
Yes.
Yeah. So he's very well trained, extremely nice guy, just wonderful person to be around and to know. And I'm looking forward to his talk on controversies in modern BPH treatment, the window of curability. So take the stage.
Okay, thank you so much for this opportunity to present at the Northwestern Advancement and Breakthroughs in Endourology. Like Dr. Krambeck mentioned, I had the wonderful opportunity to train there, world-class departments, really super efficient ORs, and of course, I obtained amazing training from Dr. Krambeck. So here are my disclosures. And the objectives for today's talk are to understand surgical management options for men with lower urinary tract symptoms secondary to BPH, to review controversies around bladder contractility and surgical intervention for BPH, and to understand morphological changes that occur in the bladder secondary to obstruction. I was originally planning to also discuss controversies around ejaculation preservation, but the talk was getting too long, so if I'm ever invited back for a part 2, happy to discuss that in the future. So the outline for today is to analyze modern surgical practice patterns, to overview minimally invasive surgical therapies and true missed options and their objective outcomes, and then to review bladder decompensation, as well as this concept of the window of curability, normal bladder function, and compensatory bladder changes, and to discuss outcomes for men with delayed treatment. So to first discuss modern practice patterns, what BPH surgeries are being performed. And this was a podium presentation done at AUA last year, and the authors looked at the AUA quality registry between 2014 and 2021. And in 2016, TURP, which is the blue line, blue bar, accounted for 40% of all BPH surgeries and decreased to 25.6% in 2021. The use of UroLift grew from 0.7% in 2014 all the way up to 30% in 2021. So it actually became the most commonly performed BPH surgery in this database. And HoLEP only accounted for about 1% of surgeries throughout the study period. Next, this was a study by Kevin Weimer and Mitch Humphreys, and they looked at the Optum Labs data warehouse for men over the age of 30 undergoing BPH surgery between 2015 to 2021, and they took an economic focus on BPH surgery. So there's 25,400 men with BPH, 40% of them underwent TURP, followed by 25% undergoing UroLift, 21% for PVP, 5% for simple prostatectomy and resume, and HoLEP 4%. So in the top right graph, they calculated the indexed procedure costs. So simple prostatectomy was the highest at $14,400, and the lowest cost for the index procedure was resume at $2,600. They also calculated the total healthcare costs, which was the index procedure plus follow-up costs for anywhere from 1 to 5 years of follow-up. And prosthetic urethral lift was actually the highest at $36,600, and HoLEP was the most cost-effective at $31,900. Limitations of this study included that they could not limit the cost only to BPH diagnoses, and water vapor thermal therapy, although is the cheapest index procedure, they could not include the total healthcare costs due to limited follow-up data. And the third study we'll look at for modern practice patterns is this one, which looked at American Board of Urology case log data between 2008 and 2021. 6,600 urologists performed 73,000 BPH surgeries, and TURP, again, was the most commonly performed surgery, followed by PVP, and HoLEP was, again, around 4.4%. When they looked at the annual UroLift case log volume, it ranged from anywhere from 101 to the highest volume surgeon doing 2,852 cases in 1 year, which is an astounding number. And when they looked at UroLift, it only accounted for 1.6% of BPH surgeries in 2015, and this increased to 32% by 2020. And they looked at factors associated with UroLift volume, and these included higher BPH surgical volume, endourology subspecialty, and metropolitan practice area. They also looked at if surgeon or patient age was associated with this, because you might think that younger men are seeking out missed therapies which will preserve their antegrade ejaculation, but they did not find such an association. So then I'll move into a quick primer on minimally invasive surgical therapies and true myths. So this is the algorithm that we're all very familiar with from the 2021 guidelines. And now ITIND is also included for prostates 25 to 75 cubic centimeters. And there are many other therapies coming down the line, such as Urocross, Zenflow, the butterfly device, Optilume, and whatever the next best thing will be in the future. So to review options, prostatic urethral lift is what we'll talk about first. It was developed in 2004 by NeoTract and eventually acquired by Teleflex in 2017. It does not ablate or remove tissue, it retracts. And there's a tab that sits in the capsular side, which is made of nitinol, and on the prostatic urethra, which is made of stainless steel. And it was FDA approved in 2013. And the AUA guidelines recommend this for prostate size 30 to 80 cubic centimeters without a median lobe. And this was based on the results of the LIFT study, which was a multi-center randomized controlled sham controlled trial. And in 206 patients, there was significant improvement in IPSS, Qmax, and quality of life, and there was no de novo ejaculatory dysfunction, and the mean catheter duration was less than 1 day. The FDA expanded the indications to 80 to 100 cubic centimeters in 2020. And I've tried looking for this data and I couldn't find it, so I don't believe it's peer reviewed. I believe the manufacturer submitted retrospective data directly to the FDA. So the AUA guidelines prioritize randomized controlled data. So it is not AUA guideline approved up to 100 cubic centimeters, but it is FDA approved. People have also looked at if you can use UroLift for those with a median lobe, and that's what the MedLift study looked at. Again, this was not a randomized controlled trial. They controlled to historic UroLift results. So that's why median lobe is not included in the AUA guidelines, but they reported significant improvement in IPSS and quality of life. UroLift has also been compared to TURP. This was the BPH-6 study, which was a multinational prospective trial across 10 European centers. And the authors identified what they call the high quality recovery, which had 6 different domains. And there's a higher percentage of men in the UroLift arm, which achieved this high quality recovery, 82% versus 53% in the TURP arm. But when you look at the magnitude of improvement, TURP was superior to UroLift for IPSS, Qmax, and post-void residual. But there is no significant difference in bother scores, quality of life. And again, there is no de novo ejaculatory dysfunction in the UroLift arm. There are 2-year outcomes reported for the BPH6 study, and UroLift outcomes remain durable. There's also been 5-year follow-up of the LIFT study, which show that outcomes are relatively durable. And when they looked at surgical retreatment rates, they were 5% at 1 year, 10.7% at 3 years, and 13.6% at years 4 and 5. And all patients who required retreatment had an IPSS of 19 or greater. But if you expand that definition of failure to include restarting medical treatment, removal of implants due to encrustation, or getting another BPH surgery, that failure rate actually goes up to 33%. Next, we'll discuss Resume, or water vapor thermal therapy, which was invented by Nixthera in Minnesota, but acquired by Boston Scientific. So this uses convective radiofrequency energy to create water vapor, and then the steam is then injected into the prostate tissue through a single-use rigid scope at 103 degrees Celsius for 9 seconds. That creates tissue necrosis, which opens up the channel. This is AUA guideline approved for prostates 30 to 80 cubic centimeters in size, even if a median lobe is present. And that recommendation was made on the results of this prospective randomized sham-controlled trial, which was also a multi-center study of 197 men, a third of which had a median lobe. And we will discuss the results of that trial in the next slide. People have looked at if you can perform Resume in an expanded size cohort, so 20 to 120 cubic centimeters. And again, because this was not randomized data, the AUA did not increase that size indication. But there was significant improvement reported by these authors. So the outcomes of that initial Resume study showed significant improvement in IPSS, Qmax, and quality of life at 12 months. The mean catheter duration was 3.4 days. 17% of men reported some dysuria that resolved usually within 3 weeks. There was a 3.7% acute urinary retention rate. And up to 3 months, there were actually 2.9% of men that reported anejaculation, but at further follow-up, there is no permanent anejaculation. And there is 5-year follow-up data for Resume as well, which shows that it is a durable procedure. And when you look at retreatment rates, they are superior to UroLift. So surgical retreatment rate at 5 years was 4.4%, and medical retreatment was 11%, again with no erectile dysfunction or retrograde ejaculation. Notable complications for these MIST include blood transfusion, cystoscopy clot evacuation, for UroLift, aquablation, and water vapor thermal therapy, as well as some pelvic and retroperitoneal hematomas reported for UroLift. And this was a study looking at the FDA MOD database. There were a couple case reports of rectal perforation occurring for aquablation and bladder perforation occurring for Resume and UroLift as well. And as we discussed, occasionally those UroLift clips will need to be removed due to encrustation. So moving on to TrueMIST, the idea behind these TrueMIST are that they are off-the-shelf BPH therapies that can be deployed with a standard flexible cystoscope in the office without sedation or general anesthesia. And the primary aim is not durability, but to be a cost-effective bridge between medical and surgical therapy. As I had mentioned, there's multiple devices that are coming down the pipeline, but there are only 2 that are currently FDA approved, iTind and Optilume, which we'll focus on next. So iTind, temporary implantable prostatic devices. This one is deployed in the prostatic urethra and the bladder neck, and it has a leaflet that secures it at the bladder neck to prevent migration. It was developed by a company in Israel, and then eventually acquired by Olympus. It only takes about 10 minutes to perform, and the idea is that these leaflets put pressure kind of at 5 and 7 o'clock to cause ischemic necrosis and expand and reshape the bladder neck. After 5 to 7 days, the device is removed using a special open-ended silicone catheter. There was a multi-center prospective sham-controlled trial, which based on those results, the 2024 AUA guidelines included iTind as an option. And in this study, they randomized men with a prostate size of 25 to 75 cubic centimeters without a median lobe. And when you look at their 3-month follow-up results, there's actually no statistically significant improvement for iTind over sham. The p-value was 0.063. So you might be wondering, how did this get approved? Well, their primary endpoint was actually the percentage of men achieving at least a 3-point reduction in IPSS. And that was statistically significant. So 78.6% of men in the iTind arm achieved at least a 3-point reduction versus 61% in the sham arm. And at 1-year follow-up, again, this was comparing iTind to the baseline values, not to a sham, but there was significant improvement in IPSS, quality of life, and Qmax. And again, no reported de novo retrograde ejaculation. Surgical retreatment rates were 4.7% at 1 year, and medical retreatment rates were also 4.7%. So Optilume, this was developed by Urotronic and originally designed for use in urethral strictures. There's a proprietary double balloon. So a balloon sits at the bladder neck to prevent slipping, and the prostatic urethral balloon causes an anterior commissurotomy. And the balloon is coated with paclitaxel to maintain urethral patency. And the Pinnacle trial is a prospective sham-controlled study looking at men with prostate sizes 20 to 80 cubic centimeters. And at 1-year follow-up, there was a significant reduction in IPSS, Qmax, and improvement in PVR. And there's no impact on erectile or ejaculatory function. The Everest 1 trial is a single-arm prospective trial with 4-year follow-up data, again, just comparing to itself. So there was significant IPSS improvement, and Qmax was sustained even at 4 years of follow-up. So in summary, MISS and true MISS, these are good options for preservation of sexual function, and our guidelines reflect this. Statements 35 and 37 recommend UroLift and Resume as options for patients who desire preservation of erectile and ejaculatory function. They result in significant symptom improvement, and they have acceptable 5-year durability, but further follow-up will be required for the true MISS. And a question I kind of want to focus on for the rest of the talk is, will these MISS and true MISS prevent bladder decompensation? Because there's a lot of momentum currently for trying to get men off medical management and offering them these therapies instead. So that takes us into this idea of the window of curability. And I recreated this slide off of what I remembered from a talk in 2022 at World Congress. Dr. Klaus Warborn was talking about this. And the basic gist was, on the left, you have a normal voiding function, and he's able to void spontaneously. And if you were to do a cystoscopy on him, it's a nice, healthy looking bladder. At some point, he may develop some bladder outlet obstruction, most likely due to benign prostatic enlargement, and he may have some lower urinary tract symptoms. And if you did a cystoscopy, you may note some mild trabeculation, but he's able to compensate as his detrusor muscle may hypertrophy and able to still spontaneously void. But then we all have seen these men where they are in chronic urinary retention with an indwelling Foley catheter. You look in their bladder and it's completely blown out, severe detrusor hypertrophy and diverticulum. And the question he kind of posed to us was, is a symptom-based management approach causing us to intervene too late? And is there a better way to make these surgical decisions? So I think there's some different assumptions we make for this idea for the window of curability. One is symptom-based management is an inadequate strategy for determining when to intervene. And then the question is, what objective parameters might we be using? And another assumption is that untreated benign prostatic enlargement and lower urinary tract symptoms always leads to bladder decompensation. But what's the natural history of benign prostatic enlargement? And another assumption is that earlier surgical intervention prevents progression of or reverses bladder decompensation. And then we have to ask, are all BPH surgeries created equally? As I mentioned, with all the momentum of trying to get men off medical therapy and onto MIS, I think that's a really important question. So we have to go back to the basic functions of the bladder, which is two main functions, storage and emptying. And the bladder should be able to store urine at low pressure. You should be able to hold an adequate capacity, have normal sensation of when you're full, not have involuntary bladder contractions, and maintain continence. And when you achieve that adequate capacity, you should be able to empty completely with adequate stream under volitional control. And on the right here is a list of all the things that can cause dysfunctional storage and dysfunctional emptying. And we know that a normal bladder should be composed of smooth muscle and collagen, but when there's injury or obstruction or denervation, there can be an increase in collagen content, leading to decreased compliance. So diseased bladders have ultrastructural changes and abnormal bladder storage. In this study of 29 patients undergoing bladder augmentation, the primary diagnoses were spina bifida and sacral agenesis, so different neurologic diagnoses, but also some obstructive diagnoses such as posterior urethral valves and prostatic rhabdomyosarcoma. And on urodynamics, all of these patients had decreased bladder compliance, even though a minority of them had normal capacity. They did a biopsy at the time of bladder augmentation, and this revealed an increased ratio of connected tissue to smooth muscle and an increased ratio of type 3 to type 1 collagen. I'm sorry, this formatting kind of messed up on my PC, but bladder outlet obstruction can lead to changes in lower urinary tract. And the idea is that the overdistension leads to increased intramural pressure, and there can be ischemia leading to denervation of the smooth muscle. And on the right, there's a figure of what the bladder looks like when it's empty versus when it is full. And you can imagine that those capillaries in the bladder mucosa, when the bladder fills, the length of them extends quite significantly, and that increases vascular resistance. So that leads to detrusor hypertrophy if the bladder is over distended, increase in type 3 collagen and fibrosis, and eventually that can lead to decreased bladder contractility. There's also altered sensation in obstructed bladders, as shown by Chai et al. In 1998. They looked at men with urodynamic proven bladder outlet obstruction, and a greater proportion of men with bladder outlet obstruction had a positive ice water test. And these findings have all been proven in animal models as well. So in the rabbit, pelvic ischemia led to neurodegeneration, and in the rat, bladder outlet obstruction led to an increase in type 3 collagen. Ultrastructural changes also occur in patients with detrusor underactivity, which is defined as a detrusor contraction of reduced strength and or duration. And this leads to prolonged bladder emptying and or failure to achieve complete bladder emptying within a normal time span. And acontractile bladder, signifies that these patients may not have much contractility at all, at least definitely not demonstrated during urodynamics. And in a study looking at 40 patients with lower urinary tract symptoms and urodynamic proven detrusor underactivity, they noted that these patients had increased collagen content and changes in muscle fiber orientation and intertwining. And in 14 patients with urodynamic proven detrusor underactivity without bladder outlet obstruction, they noted that there was disruption in the cells and disruption in the sarcoplasm, and those changes were not seen in aging bladders. So to summarize, everything that we just discussed, there are ultrastructural changes that occur in diseased bladders, detrusor hypertrophy, alter muscle fiber orientation, sarcoplasm degradation, increase in connective tissue to smooth muscle, and an increase in type 3 collagen, as well as neural degeneration. And this results in altered bladder sensation, decreased bladder contractility or detrusor underactivity, and decreased compliance. So now we have to shift to clinical studies looking at BPH. And this is a very well-known study looking at 556 men with moderate symptoms who were randomized to early TERP or watchful waiting. And they had 5 years of follow-up. And the authors found that there's greater improvement in patients who underwent immediate TERP versus those who were initially randomized to watchful waiting and later crossed over. So there's greater improvement in symptom scores and a greater reduction in post-void residual. And when they looked at complications, there is no increase in incontinence for the surgical arm. And as we might expect, the rate of acute urinary retention was lower in the TERP group versus the watchful waiting group. And eventually 36% of the watchful waiting group crossed over to TERP. Here in this table, they stratified outcomes based on baseline symptoms. So you can see that there's significant improvement in the group with high baseline symptoms. And group 1 was the group that was initially randomized to TERP. Group 3 were those that were randomized to watchful waiting but crossed over to TERP. And even in the low baseline symptom group, there was also a significant improvement for early TERP. For improvement in maximum flow rates, the high baseline group did not have a significant difference, but they did see that in the low baseline group. And kind of opposite results for post-void residual improvement. The high baseline group did have a significant improvement, while there was not a significant improvement seen for the low baseline group. So the authors concluded that, for some men, delay of TERP may have deleterious effects on symptom resolution, peak flow rates, and residual urinary volume. And if you'll note down below, the good news was that all groups had significant improvement in bother scores, and there was no significant benefit whether they went early TERP or not. And so the authors comment on this, that more bother at baseline was always associated with a higher crossover rate, and bother from GU symptoms is a critical factor in selecting treatment. So that study was published in 1998, and it just had me thinking, was there a point where symptom management wasn't always one of the primary decision makers? So I tried looking back as far as I could for AUA guidelines, and unfortunately online, 2010 is the earliest archive guideline available. But even back then, they mentioned watchful waiting is the preferred management strategy for someone with mild symptoms, appropriate option for those with moderate to severe symptoms who have not yet developed complications of BPH. And since the level of symptom distress is highly variable, it may even be the treatment of choice for someone with a high IPSS. And things haven't changed much since 2010. These are the 2024 guidelines. On initial evaluation, you should obtain an IPSS. And for surgical therapy, the indications are those who develop complications from BPH and also those who still have refractory symptoms. So in addition to gauging their symptoms, the AUA guidelines also recommend some adjunct studies. So you should be performing a PVR assessment, and you can consider assessing prostate size or shape with the cystoscopy or cross-sectional imaging, as well as uroflowmetry or pressure flow studies if diagnostic uncertainty exists. So although our prioritization of symptom management has not really changed, one thing that has really changed over the last couple decades is the advancements in medical therapy. So this paper was looking at the impact of medical therapy on TERP. It was a single institution series over 20 years, and they looked at 3 different time points. 1988, before medical therapy was used at all, 1998 when medical therapy was becoming more popular, and 2008 when medical therapy was first line. And as you might expect, the men on medical therapy went from 0% to 36% to 87%. And when you looked at the men presenting with acute or chronic urinary retention or presenting with hydronephrosis, that all increased over the study period. And when you looked at their surgical outcomes, the catheters were being removed earlier and the length of stay shortened, which likely reflects changing surgical practice patterns. But the number of men being discharged with the catheter, so failing inpatient trial avoid, increased, and the number of postoperative complications also increased. That includes things such as emergency room visits or readmissions. So although the authors kind of attributed that the patients were being discharged with catheters because they were trying to be discharged earlier than in the past, it does make you wonder if these men, because of medical therapy, were being operated on later and somehow their bladders had decompensated, and that's what accounted for being discharged with the catheter and having the increased complication rate. So there's actually a statement in Campbell's chapter 111 where they say prompt intervention is recommended because long-term obstruction can lead to anatomic and functional changes in the detrusor as well as alterations in neural networks. And we have to ask, what is the right timing? And going back to the question, do all interventions prevent consequences of long-term obstruction equally well? So in order to ask those questions, we have to understand, the natural history of detrusor contractility. So Paul Abrams published a series of papers looking at this topic over from the UK. And in this first paper of the series, it was a retrospective study of 196 men who underwent urodynamics. They looked at men with bladder outlet obstruction over the age of 40 and men of any age with detrusor underactivity. And there was at least 10 years of follow-up. So 56 men with bladder outlet obstruction were managed with watchful waiting. And at repeat urodynamics, there was absolutely no change in their bladder contractility index. And 114 of the men who had bladder outlet obstruction had undergone primary TURP, but there was, again, no difference in bladder contractility index at repeat urodynamics. They even did a subgroup analysis looking at the untreated group versus the TURP group. So the untreated group is the dotted line up here, and the TURP group is the solid line down here. And the untreated group actually had higher bladder contractility at follow-up than the treated group. And then they looked at 26 men who had detrusor underactivity and no bladder outlet obstruction. The ages ranged from 26 to 66, and there was no change in bladder contractility, even at some men had over 20 years of follow-up. You can just see kind of a flat line going across here. So in their conclusions, they wrote, our results showed no effect of time on detrusor contractility, no evidence to suggest that detrusor contractility deteriorates with long-term bladder outlet obstruction, and relieving the obstruction surgically does not improve the contractility. They also comment, underactive detrusors remained underactive, but did not get worse with time. And that could indicate that this is not an aging process. So although we kind of went over a very nice theoretical framework of detrusor bladder decompensation, these results kind of contradict that framework. So then the group looked at the natural history of detrusor underactivity. These were neurologically intact men over the age of 18, seen again at the single institution between 1972 and 1986, and they only included those who are available for repeat assessment. So of the 224 initially diagnosed with detrusor underactivity, 69 opted for watchful waiting. There was a mean follow-up of 13.6 years, and 11 men failed watchful waiting and proceeded with surgery, most commonly due to bothersome symptoms. And 58 were available for repeat urodynamics. when they compared the symptoms, there's no deterioration in symptoms. When they looked at their uroflowmetry data, there's no change in maximum flow rates, voided volumes, or post-void residual. And when they looked at the bladder contractility, there's no deterioration in bladder contractility index. There was a significant increase in the proportion of men with detrusor overactivity. So then they looked at what's the natural history of men who had presented with bladder outlet obstruction. So these were men over the age of 45, again, seen at the same institution. And there were 1,068 initially diagnosed with bladder outlet obstruction. 170 had opted for watchful waiting. Of the 170, 141 or 83% remained untreated at 13.6 years of follow-up. And of the 29 who opted for surgery, the majority did so, again, for bothersome symptoms. When they looked at those men who remained on watchful waiting, there was no change in symptoms from presentation to follow-up. And when they looked at their uroflowmetry data, there was a slight decrease in their maximum flow rates and a slight increase in post-void residual. And looking at urodynamic changes, there's no, or there was a slight decrease in bladder contractility index, but they technically remained normal with a contractility of 126 versus 134 on presentation. And there was no change in bladder outlet obstruction index, and again, an increase in detrusor overactivity. So then they looked at the influence of bladder outlet obstruction on the outcome of TURP. So the men who underwent TURP, again, from that 1,068 men, 217 underwent primary TURP. There's a mean total follow-up of 14.3 years, 13 of which was after TURP. And they did find significant sustained improvement in urinary symptoms. So decrease in frequency and nocturia, an improvement in weak stream, intermittency, hesitancy, etc. So then they compared urodynamic data for these men who had presented with bladder outlet obstruction, and their maximum flow rates did improve. The voided volume improved, and the post-void residual also decreased. And when they looked at their urodynamic parameters, the bladder outlet obstruction index, as we might expect, decreased. They're no longer obstructed. But when you looked at their bladder contractility index, it actually decreased after TURP. So it went from 139 on presentation down to 106. And there's also a significant increase in men with detrusor overactivity. The thought at the time was that men who developed recurrent symptoms after TURP was that there was tissue regrowth and recurrence of bladder outlet obstruction. But another interesting finding that they showed was that the most common reason for recurrence of symptoms was actually developing detrusor underactivity after TURP, and not bladder outlet obstruction. So then they looked at the men who had undergone TURP and later developed detrusor underactivity versus those who did not develop detrusor underactivity. This is comparing their presenting urodynamic values. So there are 50 who developed detrusor underactivity later. And when you look at their presenting mean bladder contractility index, again, both groups were normal, but the group that developed DU later on had a lower bladder contractility index and a lower bladder outlet obstruction index. So whether they developed detrusor underactivity because they received TURP too late, or whether there was some process that they were, destined to develop this, it's unclear. The authors then, in the final paper of their series, looked at the influence of detrusor underactivity on the outcome of TURP. And this was men over the age of 18 who were diagnosed with detrusor underactivity. 11 underwent primary TURP. 69 were on watchful waiting. And again, 11 of those 69 underwent subsequent TURP. So 22 patients in total underwent TURP who had detrusor underactivity, but there's follow-up data, follow-up urodynamic data only for 16 of those. And when they looked at the difference in urinary symptoms, there's no significant difference in urinary symptoms. And comparing their urodynamic data, there's no change in maximum flow rates, no change in bladder contractility index, and there was a slight improvement in bladder outlet obstruction index, but they remained unobstructed in both cases, less than 40. Then they looked at, so in the previous slide, they were comparing men who had undergone TURP presenting urodynamics versus their follow-up urodynamics. Here, they're looking at men who had detrusor underactivity and no treatment versus those who did. And what they found was that the bladder voiding efficiency actually went down in those who underwent TURP. And their bladder contractility index also decreased. And there was no change in their symptoms either. The men who underwent TURP had no improvement in their symptoms. So based on these results, they made kind of a bold statement that these results suggest that detrusor underactivity is a contraindication for TURP, and that detrusor underactivity should be distinguished from bladder outlet obstruction before surgery, which requires pressure flow studies. But I think, those results should be taken with a grain of salt because this was a single institution study. There's limited power. There's only 22 patients who underwent TURP with detrusor underactivity, and 16 of which who had repeat urodynamics. There's no interim follow-up beyond when they were contacted after 10 years. So there may have been a point where there was improvement in these urodynamic parameters that was just not captured in this study. And then lastly, there's the question of volunteer bias. Not all of the patients presented again, so that introduces some bias. So returning to this idea for the assumptions made for the window of curability, again, sorry about the formatting here. So what's the natural history of benign prostatic enlargement? Well, based on the studies we just looked at, most patients with bladder outlet obstruction or detrusor underactivity actually did not develop bladder decompensation. And thinking about symptom-based management versus objective parameters, the urodynamic parameters were stable in most patients who remained on watchful waiting. And it's clear that patients with bladder outlet obstruction have a clear benefit from TURP, and it's less clear for patients with detrusor underactivity. And this idea that earlier surgical intervention prevents progression of or reverses bladder decompensation. Well, as we saw, patients with bladder outlet obstruction definitely benefited from TURP in terms of their symptom improvement, maximum flow rates, and reduced bladder outlet obstruction index, but bladder contractility still decreased regardless of intervention. So it's unclear if greater improvement would have been seen if there was a follow-up study at 1 year or 2 years or 5 years, or if these patients received TURP too late. And the other question still remains, are all BPH surgeries created equally, which we'll answer next. So this study looked at urodynamic changes after prostatic urethral lift. It was the only study I could look at looking at this question. And they obtained urodynamics before urolift and at 3 months after urolift. There's 20 men in the study, prostate volume of 60 or less without a median lobe. And they did not calculate the bladder outlet obstruction index, but they use the Schaefer grading obstruction. So for that, 0 to 1 is not obstructed, 2 is equivocal or mildly obstructed, and 3 is obstructed. So these men went from 3.5 to 2.6. So still mildly obstructed. And I calculated the bladder outlet obstruction index using these mean values, and it was 42. So by that measure, they remained obstructed after urolift. And when you look at medical treatment failure, 6 restarted medications, and 7 eventually required PVP. There was significant improvement in IPSS and quality of life. as well as a small improvement in maximum flow rate as well. So urodynamic changes after water vapor thermal therapy. Again, this was only one study I could find looking at this question. So in this study, 17 men underwent Resume, prostate volume of 120 cubic centimeters or less, and there was significant improvement in quality of life, IPSS, maximum flow rates, post-void residual, and the bladder outlet obstruction index went from 65 to 15, and Schaefer grade from 4 to 1. So these men became unobstructed after Resume. This is the last study I will touch on, and I thought it was a very interesting one. It was looking at reversal of organ remodeling after TURP for patients with bladder outlet obstruction. So the study design was that there were a control group. So this group was undergoing cystoscopy for stone treatment and had no history of lower urinary tract symptoms. And there was a group 2 and group 3 were all undergoing TURP, and they were separated by their PDET at Qmax. So the high PDET Qmax group had pressure of 90 centimeters of water or greater, and the medium PDET Qmax group had less than 90. No patients with detrusor overactivity on urodynamics were included. And they did something very interesting. They took cold cup muscle biopsies at the time of initial surgery, and then, again, 3 months after TURP. And they examined mRNA sequencing, gene expression, and proteomic analysis. As you might expect, the PDET Qmax significantly improved after TURP. Their Qmax significantly improved after TURP. The PVR and bladder contractility index had non-statistically significant improvement, and the bladder outlet obstruction index also significantly improved. So then the authors performed next generation sequencing to look at which genes were up and down regulated in these different groups. And you can see in this figure over here that the medium PDET Qmax group before surgery had the greatest number of upregulated genes. And based on that list of genes, they created a 10-gene classifier that could differentiate between the high pressure and medium pressure group before surgery. And they created a 12-gene classifier that could discriminate between the high pressure group before and after surgery. And when they mapped out these groups based on the gene expression of those 22 genes, you can see that they differentiate nicely. So up here is the before medium pressure group. Over here is the before high pressure group. The control group is in the middle here in the green. And then afterwards, you can see that both these groups, although they are distinct, kind of overlap, suggesting that there is normalization of the gene expression. So they looked at the major biologic processes involved before intervention. And in the high pressure group, complement activation was the main upregulated process. And detrusor muscle genes were also upregulated. And in the mid pressure group, beta cell activation, neutrophil migration, and activated cytokines were the main upregulated processes. And there is downregulation of detrusor gene expression. So they hypothesized that changes in immune response might serve as an indicator for disease progression. And major biologic processes involved after intervention included downregulation of cell division and cell cycle progression. So they looked at, they wanted to find a transcription factor that was upregulated before TURP and normalized after TURP. And SOX21 was the one factor that fit this criteria. And when they looked at the different processes that SOX21 was involved in, this molecule, thrombospondin, was highlighted as a prominent signaling molecule because it's involved in cell proliferation, migration, inflammatory response. It's involved in the adaptive response of cardiac tissue to pressure overload. And it was upregulated based on mRNA and protein levels and normalized after TURP. And furthermore, it was detectable in urine. So they proposed that thrombospontin may serve as a biomarker of organ remodeling in the future. So going back to our assumptions, symptom-based management is reasonable at this time with our limited objective tools, but I think biomarkers of detrusor modeling, like thrombospontin, could bridge that gap and help us detect when to intervene most appropriately. And as for the question, are all BPH surgeries created equally? There's limited data. Again, there's only one study looking at urodynamic changes for the UroLift and Resume each, but I think the short answer is no. So going back to this window of curability and how is it defined? I mean, clearly urodynamics has limitations, bladder contractility and bladder outlet obstruction index and compliance. These parameters may change when it's too late to intervene. And I think we need better risk stratification. And one area, which is obviously a huge topic of risk stratification, is prostate cancer with active surveillance. And whereas in the past, they only had PSA and Gleason grade, they now have PSA isoforms and tissue-based genomic markers and prostate MRI. And I think we need something similar for lower urinary tract symptoms and to know when to intervene to prevent bladder decompensation, such as biomarkers and better imaging. So in conclusion, bladder outlet obstruction leads to morphologic changes in the bladder, such as smooth muscle hypertrophy and increased type 3 collagen. And urodynamics in patients with bladder outlet obstruction may demonstrate decreased maximum flow rates, detrusor underactivity, decreased bladder contractility, and increased post-void residual. But the natural history of detrusor underactivity and bladder outlet obstruction do not always lead to bladder decompensation. So we need better risk stratification tools. And I think in the meantime, symptom-based management still seems very reasonable. It was the most common reason why men in the Abraham series crossed over to surgery. And urodynamic studies still suggest that benefit from MIS is less than those of traditional BPH surgeries, but more data will be required to determine if early MIS intervention will preserve bladder function. And with that, thank you very much for your attention, and I'd be happy to take any questions.
Matt, that was a fantastic talk and very innovative and forward thinking. How close do you think we really are to genomic testing in clinical practice? Are there any companies that are working on a kit that can be utilized, or is it still in the really early research phases?
Yeah, that's a great question. I think it's still very early in the research phase. I mean, that study I cited at the end only had 3 patients in each TERP arm for the high and medium pressure. So obviously that's going to need to be validated in much larger numbers. And I haven't seen any other research similar to that, but I thought it was very interesting.
And I think, at least from my perspective, the hardest part is the patient that has severe overactivity, right? Mm-hmm. Because it's like, I feel like there's a point in time where the prostate is enlarged and the bladder is either going to become flaccid, mm-hmm. or it's going to be horribly overactive and they are incontinent. And sometimes they can switch from horribly overactive to flaccid when the symptoms go along far enough. But it's mm-hmm. like that horribly overactive patient is so difficult to manage no matter what you do. Any tricks to that?
Well, I think you're doing some really incredible research with administering Botox at the time of HoLEP for that. But, I didn't get into detrusor overactivity at all and where that, kind of comes into play as this process of bladder decompensation is occurring, because it was getting to be like way too much, because these chapters on, neurologic control and lower urinary tract symptoms are so in depth. And I think it is a really important question, and it's tough to answer. Yeah, I mean, it's unclear, who develops detrusor underactivity and how to manage those. And I mean, sometimes their overactive symptoms go away completely after HoLEP too. So I don't know like how to identify those patients, but I wish we could.
Yeah, I mean, there's people that it goes away completely. There's people that I've had to re-Botox. I think we even have a couple patients we sent to Amanda for sacral nerve stimulation, which I've seen nothing published on. So I do think that we don't quite have it figured out yet, and how to keep them from getting to that point is what we need to do. We need to intervene before that. And I agree with you 100% that the missed therapies may be giving us a false sense of security, thinking we got them off the meds, we're doing a better job, but we may not be doing a better job at all. Are you doing any missed therapies in your practice?
I am not. My partners do them, so we offer Urolift and Resume at Ohio State. So if someone is really concerned about ejaculation, I will send them to them.
Okay. Well, you didn't make eye contact with me when you said that, so I thought maybe you were.
I can't see your video. But,
I was like, oh, he's doing
Scout's honor.
Yeah. Well, I think like you, I think HoLEP is a great surgical procedure. It can fix a lot of things, but it can't fix everything. And we need to intervene at a more optimal time and help these people sooner. So anybody else from the audience have any questions that they want to ask? It's like we had a lot of people log in actually, but I don't see any questions. So so we'll go ahead and
just fantastic talk. Okay, thank you. Yeah.
Oh, another fantastic talk. See, fantastic talk. All right, Matt. Well, I'll let you go. Thank you so much for honestly, I learned a lot and I thought it was an amazing talk. So thank you. And we'll have you come back for part 2 next time.
All right. Amazing.
All right.
Thank you.
Have a good night, everyone. Thank you. Bye.